Hi everyone, welcome to my channel. My name is Maheen and I am a clinical pharmacist at a community hospital in Western Mass where I am responsible for medical, surgical, and telemetry units. I got my PharmD in 2016 and then I did a PGY1 residency in the same hospital where I continue to be employed. Over the years, I've worked with students and residents who have repeatedly told me that they benefited from having further discussions on the disease states that we most commonly encounter in hospitalized patients, as well as some of the medications that we use. So I decided to make these videos to help my students and residents, as well as all pharmacy students and residents out there. I think new or seasoned pharmacists can also use these videos to brush up on their clinical knowledge, and anyone essentially from the healthcare field will benefit from these videos, whether you are nursing students, nurses, medical students, PAs, or NPs. So please share them with any and all of your friends in healthcare. All right, so without further ado, let's dive into our topic for this video, which is on venous thromboembolism, or VTE. More specifically, in this video, I will be talking about deep vein thrombosis, or DVT. I will also do a separate video for pulmonary embolism, or PE, and another one with a detailed discussion of all the different anticoagulants that we use to treat these conditions. So, venous thromboembolism, or VTE, is a condition in which blood clots form in the deep veins of the leg or arm. This is known as DVT, or deep vein thrombosis. And when these blood clots travel into circulation and lodge into the lungs, that is known as pulmonary embolism, or PE. These conditions have significant morbidity and mortality if not diagnosed and treated on time. And the risk of recurrent thrombosis and embolization is highest in the first few days and weeks after diagnosis, therefore, making it even essential that these patients are treated on time and appropriately. So, what does the clinical presentation of these patients with the DVT look like? Typically, they will present with leg or arm swelling, pain, warmth, and erythema. The symptoms are usually unilateral, but they could be bilateral. And so when you do have somebody who presents with these symptoms, you wonder, how did they get it? How does anyone get venous thromboembolism, DVT, PE? How do the blood clots form, or why do they form? The blood clots typically form in a normal functioning body. That's how, if you get a cut and that bleeding starts, that's how the bleeding stops. Our blood is supposed to clot. The problem here is when the blood clots for no reason, and these clots then cause problems as DVT or PE. So, over a century ago, there was a guy named Rudolf Virchow who described 3 factors that are critically important in the development of venous thrombosis and now are known as the Virchow's triad. Number 1, venous stasis. Number 2, activation of blood coagulation. And number 3, vein damage. So these 3 essentially are the risk factors that all of the other risk factors fall under. They would be either one or sometimes even all 3 of these. So, history of immobilization and prolonged hospitalization is one of the major risk factors, and this is actually why all of our hospitalized patients who are immobile get prophylaxis with anticoagulation, or sometimes even just compression boots and sequentials. Other risk factors are recent surgery or trauma, obesity, history of VTE, malignancy, which is can be in hypercoagulable state, age older than 65, family history of VTE, and pregnancy or postpartum status, which can also be in hypercoagulable state. So if you have a patient who presents with all the symptoms of a DVT and may or may not have one or more of these risk factors, our next job is then to officially diagnose them. And one of the first things we typically do is get a D-dimer, which is a very straightforward, simple blood test. And a D-dimer is a degraded product of cross-linked fibrin and is elevated in almost all patients with acute DVT. Now, this is highly sensitive but non-specific. What does that mean? So, if you get a D-dimer level that is normal within the normal limits, that essentially rules out DVT. However, if you get a D-dimer level that's elevated, then the patient either has an acute DVT or that level could be elevated due to a number of other reasons. For example, it's elevated in sepsis, malignancy, if the patient has recent surgery or trauma, and it could also be elevated in patients with chronic kidney disease. So if you do get somebody with a positive or elevated D-dimer, we then have to go ahead and investigate further. Now, that typically involves imaging, and our gold standard is an ultrasound with Doppler. This uses ultrasound probe pressure to detect the presence of a thrombus, because if a thrombus is present, the vein is non-compressible. This is appropriate for proximal and distal veins, and a positive result is typically greater than 90% sensitive and specific, so therefore it is a gold standard. The downside is that it does require use of IV contrast, and some patients are allergic to IV contrast or have such poor renal function that giving them an IV contrast could actually worsen their renal function. So sometimes, actually, for some of the patients, if they have an allergy to the IV contrast, we can pre-medicate them with steroids and Benadryl, diphenhydramine, but in other conditions or in other patients that may not be appropriate. So if you do have a patient who may suffer from contrast-related complications or has contraindications to using IV contrast, then we can't do the ultrasound with Doppler. We may be able to do a CT scan, which is computed tomography, but this is not rigorously studied for the diagnosis of lower extremity DVT. So that's the downside. The third option, which is actually not even very frequently utilized, is an MRI or magnetic resonance imaging. And this remains largely investigational. There's not a lot of data to show that this could give you a correct diagnosis. So now that we have determined that our patient does have a DVT and we need to treat it, our next point is then to figure out if we're going to treat the patient inpatient. That means that are we going to admit them, or can we start their anticoagulation and send them home? So outpatient treatment is appropriate only if all of the following are true. Number one, patient is ambulatory and in stable condition with normal vital signs. Number two, there is a low risk of bleeding. Number three, anticoagulation of choice is covered by insurance and expenses or copays are manageable by the patient. So this is when you would have to decide whether you're going to use a DOAC or an enoxaparin with warfarin, and that typically is dictated by what is covered by the patient's insurance. Number four, outpatient monitoring of anticoagulation therapy is in place. So that means a PCP or hematology follow-up, and you have to make sure that you prescribe enough medication to get them through to when they have the appointment with the PCP or hematologist. And this should be in place because once you send the patient home, there should be someone out there monitoring for recurrent VTE and bleeding complications and so forth. So if your patient does meet all 4 of these criteria, then you can send your patient home on anticoagulation of choice. If not, then they get admitted. And once the patient gets admitted into the hospital, then the next thing that we have to figure out is whether the patient is hemodynamically stable or unstable, because the anticoagulation therapy that you use will depend on that. So, if your patient is hemodynamically unstable, then really your best option is unfractionated heparin. We dose it by giving a weight-based bolus, and that is then followed up immediately with a continuous infusion. And then the dose is adjusted based on the monitoring parameters. So this is definitely a very complicated regimen as compared to some of the other options that we have, but it has 2 characteristics that actually make it ideal for patients who have hemodynamic instability or who are at high risk of bleeding. And those factors are number 1, very quick onset, and number 2, very quick offset. So it starts to work immediately, and then once you turn off the infusion, the patient's coagulation status returns to normal essentially within seconds to minutes. So that is very important in somebody who has high risk of bleeding, because what if they were to start bleeding in a critical organ, and what you can do is essentially turn the infusion off, and they will be back to their normal coagulation status within seconds to minutes. And you may not even have to use any reversal agents. So for your hemodynamically stable patients, you have a lot more options. And when I'm talking about these options, I'm talking about otherwise healthy adults. And I don't mean that they don't have any comorbidities. Many of these adult patients will, but I'm talking about special populations that may require a different kind of treatment. So pregnant women, patients with severe renal or hepatic dysfunction. I'm not talking about those special populations. I will discuss those specifically when I talk about the specific anticoagulants in more detail. So your hemodynamically stable patients, your top choice typically is one of the DOACs. These are direct oral anticoagulants, rivaroxaban, apixaban, dabigatran, and edoxaban. And I've heard a lot of other names that are used for these drugs. NOACs, when they first came out, stood for novel oral anticoagulants. I think I've also heard TZOACs for target-specific oral anticoagulants, and there's probably a bunch of other names. I just like DOACs. I think it's straightforward. It really clearly describes what they are. And so these DOACs are actually preferred by the CHEST guidelines for similar efficacy, reduced need for monitoring, and lower bleeding risk as compared to warfarin. And typically the top 2 choices are rivaroxaban or apixaban, because either of these you can start right away. They do have a loading period, and that period is different for both of these medications. And in that loading period, the dose is much higher, which is then transitioned to a lower maintenance dose. So we have to be very, very careful and make sure that we dose these agents appropriately, and also make sure that the patient knows when to go to the maintenance dose and takes that appropriately. So the other two, dabigatran and edoxaban, they can't be started right away. They can only be started after the patient receives 5 to 10 days of a parenteral anticoagulant, which could be a low molecular weight heparin or unfractionated heparin. So, why is that? And the only reason I could really find was that because that's how they were studied in the clinical trials that got these agents approved, that what the regimen was, that the first 5 to 10 days of therapy, the patient was on a parenteral anticoagulant and then were transitioned to either edoxaban or dabigatran. So that kind of defeats the purpose of starting somebody on an oral anticoagulant so they're, maybe observed for one day and then sent home. Because for unfractionated heparin, the patient will have to stay in the hospital for the whole 5 to 10 days. And the low molecular weight heparin, they can do it at home, but there's a lot of teaching that's involved, and you have to make sure that the patient is either willing to do it to themselves or has somebody who is able to do it for them. And so you typically don't see these two used for VTE for essentially this reason, among others. And so it's important to differentiate between this regimen for edoxaban and dabigatran, where you first have to use a parenteral anticoagulant and then you transition to dabigatran or edoxaban only, versus the bridge that we do with a parenteral anticoagulant and warfarin. So with that, we typically use either infection heparin, or typically it's low molecular weight heparin or enoxaparin, and we continue to use that while the patient is on warfarin. So we use both, and then once the patient's INR is 2 or above, then we stop enoxaparin. So that's called the bridge that we typically do. This with edoxaban and dabigatran is not a bridge. It's monotherapy. You start with parenteral anticoagulant and then you transition off to dabigatran or edoxaban. They should not ever both be given together. So, for some reason, if your patient cannot take a DOAC, that could be in a patient um, whose insurance is not covering these or has a very high copay, then warfarin is an option, and you would do the bridge that I just talked about. So you would start the patient on enoxaparin and warfarin together, keep monitoring their INR daily, and once the INR hits 2 or above for 2 consecutive days, you can stop the enoxaparin and continue with warfarin by itself. And for the treatment of VTE, it's absolutely critical that the patient is on the bridge if they're going to use the enoxaparin. The warfarin. They cannot just go home on warfarin and wait till their INR is in range. They have to absolutely be on enoxaparin at the same time. Because remember, the first few days have the highest risk of recurrent DVT, so if you don't treat them appropriately during that time, then they have a very high risk of complications. And so there might still be some people who just may not be appropriate for an oral anticoagulant. So this could be patients who have poor PO intake or have absorption issues. They may not be able to take an oral anticoagulant, and in those patients, low molecular weight heparin would be preferred, something like enoxaparin, given sub-Q. And another option is fondaparinux. It is not used very often, But it is an acceptable alternative to low molecular weight heparins. Um, but it's typically usually reserved for patients who have a history of HIT, and are not able to take any of the heparins. HIT is the heparin-induced thrombocytopenia. So now that you've picked an appropriate anticoagulant for your patient, for not even your hemodynamically unstable patient who was on unfractionated heparin could now have been stable, and now you've also transitioned them to an appropriate anticoagulant that they can continue to take at home. The question sometimes is, what is the duration of treatment? So for those of us who really work on the inpatient side, we typically are not the ones to determine this duration. Typically, it's the PCP outpatient or the hematologist that the patient sees will determine how long the patient needs to be on it. But it's good to know sort of the general principles of what determines the duration of treatment. And that depends on whether the DVT is provoked or unprovoked. What is a provoked DVT? It is a DVT that is caused by a known event. So that could be surgery. Remember, that was one of our major risk factors. Hospitalization or immobility, estrogen therapy, or pregnancy. So that's a very known specific risk factor um, that could have contributed to the development of that DVT. Now, it could also be unprovoked DVT, and that is when you essentially cannot find an identifiable provoking cause for that DVT. It's not apparent. Well, the duration of therapy in general for provoked and unprovoked DVT is at least 3 months. So, in these 3 months, the risk of recurrent thrombosis is highest if the patient is not anticoagulated. So, remember that this is an anticoagulant that we're talking about. These are not thrombolytics, so they don't, all of these anticoagulants, they don't actually break up the clot. What they do is that they make sure that the clot isn't extended or that new clots aren't formed, but it's essentially your body that is doing its normal lysing. What we're trying to do in the first 3 months is that make sure we don't get another clot or extension of the existing clot. Now, anticoagulation therapy can be extended to 6 to 12 months if patient has a persistent but reversible risk factor. So let's say their DVT is related to their malignancy, but that's curable and they're currently on the treatment. So they may only be on the anticoagulation while they're on that treatment, and once their malignancy is cured, they may not need to remain on anticoagulation. And now there is a certain small group of patients that may actually remain on anticoagulation therapy indefinitely. And these patients are typically patients who have low to moderate risk of bleeding. So their risk of bleeding obviously cannot outweigh their risk of recurrent thrombosis. And they either had an unprovoked DVT and symptomatic PE, recurrent unprovoked VTE, active cancer, or have antiphospholipid antibody syndrome. So those patients will require indefinite anticoagulation therapy. So that brings us to the end of this video. I hope it was informational. I hope it was useful. And if it was, please continue to share it with anyone that you think may benefit from it. Thank you very much, and I will talk to you in the next video. Bye.